Okay, hello. I'm going over newborn assessment for you. Lots of different characteristics of the newborn. You don't have to memorize this, but I don't want any of it to be a surprise either for you when you're actually assessing a newborn. So in this first picture, we see the baby just freshly out, placenta still attached. The cord is, kind of pulling, and the cord is nice and thick. It's got Wharton's jelly. You can see the connective tissue. This bulging vessel is the umbilical vein. This smaller vessel is one of the arteries, two arteries, one vein, still attached to mama. Baby's very wet. It's been nice and warm at a constant temp because of the amniotic fluid, been floating in that amniotic fluid in utero. And so there's a nice buffer there. It's dark, and baby is just touched on all sides by that uterus because it's curled up in a little tiny ball. So when they come out, noises are very sharp, the lights are bright, and it's very cold, and especially because baby's wet. So that is important because that baby has to take the biggest breath it's ever going to take in its life to really open up all the alveoli and clear that airway out of the fluid that's been living in it. Part of what happens is also a vaginal squeeze. So as the baby comes out through the vaginal passageway, it gets squeezed, its thoracic area gets squeezed. And so some of the fluid that's been residing in the alveoli in the lungs in utero gets squeezed out. When they take that first deep breath, they inflate the alveoli. It also pushes fluid out. So that cold, loud, bright, those are mechanical factors that help that baby stimulate that baby to take the biggest breath they've ever taken. So we do not want babies to get cold right after they're born, and so we definitely need to quickly dry them off. This baby is being born via C-section. You can see he's half in, half out, and he's already crying. And same deal. The only thing is that you cannot mimic that vaginal squeeze with the C-section incision, and so you have to. Babies who are born via C-sections tend to be wetter. Their lungs are wetter. They tend to swallow a lot more amniotic fluid. And so we have to watch them pretty closely during their transition time. Transition time for a newborn is 72 hours. Usually they're with us for 24, little over 24 to 48. So that's where teaching is so important, teaching parents. This baby is nicely flexed. One of the things that a flexed posture tells us is that the baby is term. So this is a term newborn, nice and tightly flexed, intact neurological system. It's mature for that age. And also that this is the way that it helps baby to stay warm, right? That's one of the mechanisms that baby has to try to keep heat in, is the flexed posture. The other thing is brown fat, which is unique to newborns, and there is a very limited amount. And once the baby's burned through that, it's gone, and the baby can get cold stressed, and that's very dangerous for a newborn. It affects everything. This is, in contrast, a preterm baby. It's been out for a little while, but you can see the ears are still folded. The skin looks almost mottled, but it's just because these are the vessels that are so close to the skin. And of course, preterm babies don't have that flex posture because they have a very, very immature neurological system. So, okay, so this baby is obviously just new again. And for the first 2 hours, we want babies, if they're stable, they stay with mama and significant other. And you want baby to be skin to skin with mom as much as possible in those first 2 hours. Being baby skin to mama skin will help regulate temperature, helps regulate respirations and heart rate. So it really helps stabilize that baby. Before the baby leaves the room, or the nurse leaves the room from recovery, we're going to make sure that we weigh and measure the baby. So we measure head circumference and length, and we weigh the baby in grams and convert to pounds also. And then if you notice, there's over on the left-hand side, there are bracelets. Baby and significant other and mom have matching bracelets. It's got the information, the sex of the baby, the time the baby was born. And it also printed on the bracelet is a number, and we verify the number whenever we take the baby into the room. If baby and mom have been separated, we are going to verify bands before we give the baby to the mama. You don't want to give the wrong baby to mom. One of my friends had her baby given to somebody else, and the lady actually breastfed the baby, which is a horrible thing, and it really traumatized my friend. So you don't want that to happen. When we first go into the room, if mom and baby are together, we still verify bands. And this is a safety measure. And it also makes parents feel more secure that you're following these things. Baby will have bands, one on the wrist, one on the ankle. They tend to fall off. Nowadays, the cord clamp here, right here, will have that number on it also. And then the cord clamp doesn't get taken off until baby leaves the hospital, just before then. So if you look over here, there's a syringe with some medication. It is vitamin K. We'll give that in the right vastus lateralis on the newborn. We give vitamin K to newborns because of vitamin K stimulates clotting factors. Babies, and vitamin K is synthesized in the gut. You got to have normal flora in your gut to synthesize vitamin K. So babies have sterile guts. So until they get some good bacteria in their guts, they will not synthesize vitamin K, and they could have trouble getting those clotting factors to work. So we will give them vitamin K. Now, parents can refuse that if they don't think it's going to be an issue, if the baby's not going to be circumcised right away, etc. But breastfeeding babies will start having normiflora in their gut within 48 hours. It will start. It takes bottle-fed babies a lot longer, a week or two, to have normiflora in their gut to start synthesizing that vitamin K. So vitamin K, giving that is a safety measure. When we do vital signs on babies, we go from the least invasive to the most invasive. We don't do blood pressures. We do respirations first. You leave the baby quiet and wrapped, and you count their respirations. If you can, just by looking at them. They're abdominal breathers, so you can put your hand over their abdomen, and then you can see your hand rising and falling. Babies are periodic breathers, so they stop and start. That's perfectly normal. So that's one of the reasons why it's so important to count their respirations for a full minute. You can't shortchange them. So if when you're listening to the lungs, and the heart rate, you can just sneak a warmed stethoscope in under their blanket. And if you, on the right side of the chest is the best place to listen to breath sounds, but you will hear the heart rate and you will hear um, ab um, abdominal bowel sounds, just because there's so much stuff in just a really small area. So you really have to work to isolate those sounds. Important to listen to the heart rate and the heart sounds for a full minute. Again, babies who are in transition, especially in the first 24 hours, will have an intermittent murmur. Remember, all those shunts that we talked about in the first class are closing, and it takes some longer than others. And it's just a really delicate little leaves of tissue that start forming over those holes in that system. And so sometimes they kind of start and then they kind of break up, and then they will kind of go back and forth, or there's maybe a little leaking. And so you hear murmurs. And so that's normal in the first 24 hours. If they still have a significant murmur within after 24 hours, we will probably get an echocardiogram just to make sure that they don't have a cardiac issue. The other thing that we'll do is we put a sat monitor on the right foot and either hand, and that helps diagnose cardiac issues also if there's a difference in the O2 sats. So that's just another thing that we look at. That's after 24 hours also. So you watch for the respirations, you listen for the heart rate, and then we do an axillary temperature. Axillary temperature is under the arm, of course, and you have to get it seated right in the pit of that underarm, and then hold the baby's arm to the area. So sometimes that makes them cry, but you've already listened, so you don't have to worry about noise at this point. And this is how it is. Actually, if you have cold hands, that cold can actually transfer through the arm because it's so little and affect the temperature. So I often will put a couple layers of blanket between me and the baby's arm. So a couple things that you may notice here. We have, if you look, hands that are blue. This baby is pretty brand new. The hands are blue, and that's normal for the first 8 to 12 hours. Within 24 hours, they'll be nice and pink, but that's just because the those are the tiniest capillaries, and it just takes a while for those to pink up. That's called acrocyanosis. It's incredibly normal. Acrocyanosis are the hands and the feet. Normal. Something else you might notice is the eyes look really goopy. And that is because we put erythromycin ointment on the eyes after baby's born because of when the baby goes through the vaginal vault, they could pick up any infection. And so there used to be enough blindness caused by gonorrhea that in newborns babies, that most states have state laws saying that babies have to have erythromycin in their eyes. And I think parents could probably refuse this too, but again, they have to sign a release form that they did refuse it. So, but the baby's nice and active, awake at this point. This is the wrap that we practiced, we will practice in OB Skills Lab. I call it a doo-doo wrap. A burrito wrap is another way. Parents think that you are amazing magical wizards if you know how to do this, and you're going to be expected to teach parents how to do this. Really important to keep a baby very warm especially in that first 72 hours. And think about the fact that they are used to being in a tiny, tight little ball in their mom's uterus. And so it makes them feel more secure if we swaddle them. This baby looks like it just got off the warmer, and we somebody missed a hand there, but um and it looks like he's double or triple wrapped. And sometimes we'll do that. If a baby's having trouble maintaining their temperature, we will dress them and then put several layers of blankets on them. Here are the normal vital signs. Pulse rate is the same as the fetal heart rate. Respirations 30 to 60. And then the temperature, if you'll notice, 97.5 to 98.6, not over 100.4. You want to, that for us, we will report anything that is 98 and lower. And basically, if you have a low temp, axillary temp, switch to the other side, check the other side's axillary temp, and then if it's still lower than 98, we will be sure we report it to the nurse, and we will have to have an intervention. So we will probably dress the baby, double wrap them. We may put them on a radiant warmer to warm them up really good. The temperature definitely affects transition. So if baby has a low temp, they're going to start burning up all their blood glucose, and they will to try to keep themselves warm. And then all of a sudden they are, have a terribly low blood glucose, and they won't eat. They're floppy, they're cold, and babies can die very quickly from being cold stressed. So, and the blood glucose and the temperature go hand in hand. So when one is bad, the other is probably bad too, and we definitely need to intervene in that. Okay, so this baby is probably 35, 36 weeks, has a lot of that white cheesy stuff on them. It's called vernix caseosa. Vernix is what we usually call it. People usually don't talk about caseosa. And in utero, since baby is growing in utero, they're covered by this so that it protects the skin, right? If you hang in water a long time, your skin gets all wrinkly, and then when you get out, it's very dry and peely. So babies are totally covered in this in utero. Then as they get bigger and it gets more crowded, it rubs off against the walls of the uterus. And so term babies don't have a ton of this like this. We, for the most part, wipe the excess off, but it's definitely something that you'll see under arms and in any creases the baby has. And we have to be sure we tell parents that it's really normal. It's good to keep it on the skin. It's I call it Mother Nature's cold cream. So it's very good for baby skin. So it's not something that we need to worry about like washing off. It's very thick and cheesy and kind of greasy. So it's good stuff. And babies who are born post dates or after term have very little of this. And so they tend to have very dry, cracked skin. This is the other thing that covers the fetus's skin in utero, and it is called lanugo. People mix up lanugo and vernix. You're definitely going to have to know those terms. So, but lanugo totally covers the baby. You can see this baby was very preterm. It doesn't have very much fat, subcutaneous fat on it. The skin just kind of hangs there, and he's covered by lanugo. You will see lanugo on newborns, but usually just sort of like in the shoulder area, and just a little bit. Again, with term newborns, it rubs off in when the baby is rubbing up against the walls of the uterus as things get really crowded in there. So Lanugo. And it just protects the baby's skin. It also, I suppose it helps hold that Vernix caseosa on, right? Okay, noticing this baby, hands are very blue, but centrally this baby is nice and pink, looks really good. And so the nurse is putting purple stuff on the cord. We used to put an antiseptic on the cord to help it dry faster and help stop infection. That stuff is really messy. It got purple all over the place, but we nowadays we don't. We just let the cord dry on its own. You had cord care in your prep, and we would use a Q-tip around it in a lot of places. And I don't know what we're going to be doing at Banner Desert, but in a lot of places now they don't do anything with the cord. They just let it go, let it dry up. You want to be sure that you fold the diaper underneath the cord and leave it open to air as much as possible so that it dries up and falls off. Usually 7 days to 2.5 weeks, it will dry up and fall off. There might be a little spot of blood when it comes off, but that's normal. Parents need to know that if it starts smelling funky and if there's any exudate, that they need to call their doctor because a cord infection at the insertion site can cause baby to become septic. Okay, so this is called erythema toxicum. The common name for it is newborn rash, and there's blotchy, sort of puffy red areas. And then they have like a little tiny whitehead in the middle. This is incredibly normal. Parents should not be alarmed by it. Like this baby, some babies have a lot of it. Some of it's on their face. It just doesn't, it's just baby sensitive skin. And they shouldn't do anything about it. It will go away in a few days. And you can assess a baby head to toe, and then 20 minutes later, parents will look at them and they have a rash. It's just one of those things that comes and goes, and it seems like it moves a lot, but it's just part of the newborn's transition. And here's newborn rash on the face. This is like really fine newborn rash. This is a stork bite. Baby has some here and here. It's just nevi, that little vessels that are really, really close to the skin. Usually they disappear in the first year. Those vessels do stay close to the skin. If I'm having a hot flash or if I'm upset about something, you can see my stork bite. So very, very common. And it's really common for babies to have them like above the eyes and in between the eyes. Definitely a common thing. These are Mongolian spots. Babies of color will have Mongolian spots. It's just pigment that they have. My daughter Kira has had Mongolian spots. Usually they fade within the first couple of years of life. Sometimes it takes longer. You would hope that all emergency personnel would know about Mongolian spots, but people see these and tend to think that maybe they're bruises. And so it's important to document them in the newborn chart before the baby goes home so that there is a record of them at birth. We don't do anything with them, obviously. So this is infant jaundice. Newborns after 24 hours old will commonly get jaundice. It just is because they have immature livers and they can't process the destroyed red blood cells fast enough. And so the fetal hemoglobin starts breaking down, and the result of hemolysis is bilirubin, and it has to get processed through the liver before it can be flushed out the body in the urine and the feces. And so babies can't keep up, and so they get jaundiced. Usually, if baby's eating well, drinking well, this is not a problem, but we have to really keep track of how fast the bilirubin goes up. And so we will be taking blood and checking the bilirubin levels, especially, for a baby like this, it's pretty darn jaundiced. So, if it goes up too high too fast, it can cross the blood-brain barrier. It will stain the brain, and it causes brain damage called kernicterus. So while this is benign, we do have to keep a monitor on it and make sure that it's okay. Let's see. If a baby is born jaundiced before 24 hours, has some jaundice, they have a pathology and they're probably pretty sick. This is what we do for jaundice. They go under these lights. We have to protect the eyes because of the UVA rays, and UVA, UVB rays. It's kind of a blue light. And the that photo light, the light that is shining on the skin, will break down the extra bilirubin, and then it gets flushed out in the urine and the feces. Now, if it is not so bad, we can send baby home. They can do Billy lights at home too. We just have to make sure the baby stays hydrated because they can lose water because of this. And they get kind of lethargic, so you really have to push them to eat. But there are also Billy blankets, the Billy lights that we can just wrap baby into. We still have to protect the eyes, but that at least mom can hold the baby, etc. So, but that's what we do for that. Only if it's too high. If babies are going home within 24 hours, you will often see, and they're already jaundiced, starting to get jaundice, they will have them bring the baby to the clinic to check a Billy afterwards. This is milia. Milia, it's just clogged sebaceous glands. And again, parents shouldn't pick at this. Just leave it alone. It will go away within the first couple of weeks. Yeah. So, and again, totally normal. And most of these things, we just have to keep reminding parents that things are normal. If you look at this, you can see that, we know that the baby's skull bones are not fused. And so this is in the way. So we see then these blue areas are called sutures, right? And with the openings, here, this is a diamond shape, this is a triangle shaped. So there are 4 bones that meet here, there are 3 bones. That is because the baby's head needs to fit through the pelvic and vaginal passageway to be born. And so they will actually overlap. We call that overriding sutures. They'll actually overlap. And so babies are often born with what we call molding. The head skull molds to the shape of that vaginal passageway. And so babies are born cone head babies. We saw that in class. And it kind of freaks parents out. We usually leave a hat on the baby, but this is a baby after 24 hours. So it gets better. If the molding is really bad, then babies, we will, it will take more time for that molding to resolve, but it will in fact resolve. And then it will, over the first 2 years is when these sutures kind of close together and fuse. So, okay. All right. So what you might notice with this baby is that it looks very cyanotic. And this, in fact, will look like a baby that has circumorocyanosis, where it's blue around the baby's lips. But if this baby actually had circumorocyanosis, its lips wouldn't be nice and rosy pink like this. This baby actually probably came through the vaginal canal very quickly. And if they make a turn really quickly and come down quickly, they can get their faces get really, really bruised. And that's what happened to this baby. And you can tell the nail beds look fairly pink. Its hands are pale because of acrocyanosis. And then if the lips were really pale, the gums were pale, and we had this circumorocyanosis, we would know that the baby was having an oxygenation problem, but not so much. Babies who have any collection of blood anywhere, like bruising, any kind of birth trauma, will get a higher bilirubin level because there's more destroyed red blood cells. So oftentimes they have to go under those Billy lights. These are forceps. This is a delivery to help mom deliver that baby if mom is not able to push, if it's a really tight fit. Usually baby is closer to being out than this, but the doctor will put forceps around the baby's head. We also call them salad spoons. And when mom pushes, doctor will pull. So, and you can see the baby has to go around a curve to come out. So it can be it can be a tight fit. This is a vacuum extractor. They actually, with suction, attach this to the baby's scalp. And as mom pushes, doctor pulls. Sometimes if the doctor's pulling too hard, that vacuum extractor will pop off. You can have a total of 3 pop-offs, and then you have to stop. You can't put it on anymore. And this can cause issues in the newborn. I hate the vacuum extractor. So when a baby is pressed up against the cervix for a really long time, that baby's head can get something that we call caput. Caput secundum, but you will hear caput. You will most likely see some caput in a baby in the nursery. And this is just a layer of the scalp that has a collection of serum in it. It's swollen. There's edema. And it will take a few days for that to go down. Baby probably has a headache, and it feels very soft and mushy, like pushing on a water balloon. So baby scalp will feel really mushy. This, however, is called a cephalohematoma. So instead of just serum and fluid, it is actually blood. So baby has bled into, it's a different layer of the skull. And how you know between the two is this is very soft and spongy. This is like a hard bump. It also, a cephalohematoma, should move this again. A cephalohematoma does not cross the suture lines. Okay, so it will be contained to one side or the other. Sometimes you'll have 2 cephalohematomas. And but either one is a birth injury for sure. And this is an example of caput. It's just, there's a whole bunch of swelling here from that baby. And, we have special like little gel pillows for them. And it's almost like their scalp just kind of hangs down because it's so heavy from the fluid. It's an ouchie. So these babies tend to be crabby. This baby is a little older too, and he's crying. This is the cephalohematoma, and they would feel totally differently. And again, the baby with the cephalohematoma is at higher risk for a higher bilirubin level or jaundice. This baby was obviously stuck in utero. You can see the nose is displaced to one side, and they used forceps to get the baby out. And you can see that the forceps caused bruising. And forceps can actually cause nerve damage in the face. Besides bruising, they can cause a lot of bad things. And if a baby gets so stuck, sometimes it's often better to just do a C-section and get that baby out. So, because this baby was definitely either wedged in the wrong way, or there just wasn't any room. This baby, this was in my own nursery, and this baby had a pop off from the vacuum extractor 15 times, and somebody should have slapped that vacuum extractor out of the physician's hands. And because I don't even know, I wonder if this baby ever grew hair in these areas. And you can see this is bruising all along here. Was so much trauma to that baby's head. It looked worse than the picture for sure. Just a terrible, terrible thing. This is, you can see the eyes are kind of crossed, and we call crossed eyes strabismus, but with babies, it's called pseudostrabismus because they tend to have very immature ocular muscles. And so if parents ask you, are my baby's eyes crossed? They seem to be going in all different directions. You just tell them, nope, it's normal. Pseudostrabismus, as the eyes strengthen, they will be able to focus, and it will get better. And then this is putting the erythromycin onto baby's eyes. And this is what babies look like afterwards. This baby, you can tell, is having a nice lusty cry. This picture I have to show you because of all the puffiness that you see around the eyes and the cheeks. That's called periorbital edema. Babies are born with extra fluid on board, and so they never look the same, and they change significantly in their first 3 days of life. And babies will also lose up to 10% of their birth weight. It's very normal for babies to lose some fluid after they're born. We don't want it to be more than 10%, then that tells us that they're not eating well, and they could get dehydrated. And getting dehydrated for a baby is very dangerous also. So this nurse is eliciting the suck reflex. Babies have to have stimulation on the roof of their mouth, that upper dome, the highest part of their mouth, to elicit the suck reflex. So when we're testing it, I usually just use my little finger, a gloved hand, and stroke the top of the roof of the mouth, and they will start sucking for you. So this is a good reminder. So when helping with breastfeeding, the baby should not just be sucking on the nipple. The whole areola should be going into the mouth. And that is so the hard nipple, can reach the top of the roof of the mouth and stimulate the suck reflex. Same with a bottle. When you're helping a parent bottle feed, you want the tip of that nipple to touch the roof of the baby's mouth, which is a whole different angle than they would need to think about. But babies have to be taught to do some of this stuff, and so we just have to help them out. So you aim the tip of that bottle towards the roof of the mouth. The other thing is that we don't bathe babies usually before 24 hours unless they have meconium staining all over their skin. But babies, it's better for babies, helps them with their microbiome. It helps with breastfeeding if we don't bathe. We used to say 8 hours, and now they're saying, then it was 24, and now they're saying 48. So we may not do baths in the hospital at all. We still want to teach parents how to do a bath. That's why we do it in boot camp. But the upshot is for nurses is that if your baby hasn't been bathed, you need to wear gloves the whole time that you're taking care of them because of the body fluids that are on their skin. This is just something that we do. We measure the line between the outer canthus of the eye and the tip of the ear. We're checking for low set ears. If baby's ears are low set right after delivery, it could be because there's molding. So this really isn't an accurate assessment until after the molding is all gone. So, but it's there can be genetic issues if a baby has low set ears. You may notice the color in this baby looks like we took this picture in a sunset, but those nipples on that baby are very red and swollen. And that is a normal finding. It's an expected finding again, because babies, boys and girls, end up with mama's hormones. And so you will see breast swelling on both sexes, also swelling of the genitalia. Something you might notice on this baby is the really prominently cracked and peeling skin. And that tells me that this baby was post dates. So that lanugo and the vernix were not protecting them, and they were in that amniotic fluid with no skin protection. And so their skin will be dry and cracked. With this baby, we're just checking femoral pulses. Usually I will use my ring finger because that has the weakest pulse. And it's really easy to press too hard and occlude the pulses. This is about the area that we will find it. They're hard to find. This is meconium. That is the first stool a baby will ever have. Meconium, the meconium plug sits in that in the baby's GI tract for a long time during pregnancy. And so this is what we can use to check. We'll gather this and send it off to the lab to see if baby's been exposed long-term to drugs. So we'll do check, we'll grab meconium, and also maybe put a bag on the baby to check the urine, to do a urine drug screen. And we do urine drug screens on mamas too. The meconium stool, it's really important to pass that. If they haven't passed it right after delivery, which is pretty common, or in utero, we want to make sure that the baby's first temperature is a rectal temp, so that we know that the baby's anus is intact. And then we watch for this. We want this to happen within 24 hours. If baby doesn't pass their mucus plug within 24 hours, it can mean that they have cystic fibrosis. That's a sign of cystic fibrosis. Almost always that this is what happens. This is black to kind of greenish black. It's more like a gel than, that more creamy stools. And so that is what you'll see. If it dries on the baby's skin, it is really hard to get off. So you need to use lotion, use the baby lotion that's in the baby's drawer to get it off. That works like a charm. This baby is bottle feeding, and I think you can kind of see that nipple is tipped up toward the roof of their mouth. And this baby has beautiful highlights in its hair, so that's how it got in here. This baby is brand new, and you can see the vernix on them, and then also that her genitalia are very swollen. Again, that's mama. That is mama's hormones. Baby girls will also have something that we call leukorrhea. It's kind of whitish, clearish. Sometimes it might even have streaks of blood in it. Very normal and expected, although it really freaks parents out again. And it's, again, just mom's hormones. This baby also has swollen genitalia from the hormones, and it's a great picture of the tonic neck or fencing reflex. We turn the baby's head to one side, one arm goes out, the other goes up, one leg goes down, the other goes up. So hard to elicit when they're in their cribs. They need to kind of be on an open area. We do circumcisions. Hopefully they're not doing them as much in the hospital. We'll see when we get there, but it's better to do them when baby's a little older, in my opinion. But this is the baby has phimosis, which is just the baby has an intact foreskin. When we circumcise, we take the foreskin off. Some cultural and religious traditions believe in removing the foreskin or doing circumcision on males. A lot of times, if dad is circumcised, then the babies will be circumcised too. There's pros and cons to each. It's a very controversial subject, but we swaddle the baby's top half and then we put them on this board and tie down the legs really well. And then they will do a block here so that it's numb. And then what they do is pull that foreskin up. The foreskin is attached to the head of the penis by adhesions. So they're breaking up, he's breaking up the adhesions there. Then they slide this clamp on, making sure they don't have the tip of the penis on it. And then they close it off. It squeezes all the vessels that are in the foreskin. And then they take a scalpel and lop it off. They take off the clamp and push the foreskin down, and there is the penis. And we use Vaseline on a 4x4 so it doesn't stick to the diaper. We have to watch really closely for the first 4 hours to make sure it doesn't bleed. There's a big vessel down here. We need that clot to stay intact. Usually the first time they pee, they'll cry because it's sore. And they tend to be really sleepy right after circumcision. So it usually messes with breastfeeding. So we want breastfeeding to be really established before we actually do a circumcision. That's why I don't like them in the hospital. And then also it's cheaper if they do them in the clinic, in the pediatrician's clinic 2 weeks later. So it's a better deal. This is the Ortolani's maneuver. I'll show it to you guys. This is just to make sure that the head of the femur is well seated into the acetabulism. If the acetabulum isn't developed all the way, it will be loose and there'll be a clicking sound. And then baby will usually have to wear a harness until it does develop all the way. This baby has beautiful hair, really thick. And then also what's happening now is they're giving in the left vastus lateralis, they are giving the first of the hepatitis B series. We start that as infants because it will keep them safe from hepatitis B. And hopefully you guys will get a chance to do that. We used to do footprints as like an identifier, but you can't identify any baby from the footprints. That would be kind of crazy. Now we just basically do it for parents' scrapbooks. So, and we don't use an ink pad that gets their feet all black. When we draw blood for baby for a bilirubin or a blood type, we will use the outside of the heel and we take a lancet like this and do a heel stick, and then we squeeze blood out. It really helps if we warm up that heel with a heel warmer before we do this, and then the blood will run a little bit better. So they will do that. You want to stay on the outside of the heel because of the nerves that run down the middle of the heel. You can cause permanent nerve damage. Whoops. On one. This is something that we do on all babies. Also, it's called the PKU. It's named that. It's basically a metabolic screening. It's named, we call it PKU. That's kind of the slang name because a PKU was the first metabolic disease that this tested for. So we do a heel stick and we squeeze blood onto this paper. We let it dry and then it gets sent to Iowa and they do testing. And parents never really will never really hear about this or the results because normally babies don't have any metabolic problem. But this tests now for hundreds of metabolic diseases. So it's a good thing. This is the baby's first bath. We do a sponge bath because we don't want to submerge that cord into water and really get it soaking wet. We want it to dry faster. This baby is under a radiant heat source having his bath. So we have to be sure we tell parents to do the baby bath in a warm room with maybe even a space heater. Be sure they gather all their things up. No drafts before they want to gather up all their stuff so they don't have to, they wouldn't want to leave the baby unattended, of course. And so they just do a little sponge bath. This is a shampoo. You will see nurses rinse the baby's head underneath a faucet. That's absolutely wrong because you never know how hot that water is coming out. We will shampoo the baby, especially at first, and use a comb because there's tissue and blood clots and gunk in their hair. And so they get a fine-tooth comb to kind of comb that out. This is an example of the palmar grasp reflex. I think a lot of people have, if you push onto the baby's palm, they squeeze your hand. It's one of the primitive reflexes that we check for. The other thing with this picture is you can see that baby has really long nails. So sometimes we put socks over their hands so they can't scratch up their face. But these nails are actually attached to the fingertips. So it's really easy if a parent were to try to trim these nails, they can easily cut the fingertip and there's lots of bleeding. So I like the idea of you can get baby emery boards or little nail files and just gently filing it down. Some people will tear it, but you can actually tear it into the finger too. So you just have to be very, very careful with that. This is the plantar grasp. Again, just push right underneath baby's toes. This is an example of the rooting reflex. I know in the ATI video, she's rubbing all over its face. Really, you just have to stroke one cheek and the baby should turn its head, open its mouth, stick its tongue out in the direction that you were turning it. Sometimes, the blanket will touch their face and they'll do that. And rooting is definitely a sign of hunger. Another sign of hunger is not smacking their lips or sucking on their hands. Crying is a late sign, so we never want to wait till then. And then this baby is showing the suck reflex and the plantar, the palmar grasp. This baby is doing the stepping reflex. You just touch the baby's feet against a surface and they will automatically step up. And this is just kind of showing the startle reflex or the Moro reflex. And it's just you change the baby's equilibrium and their arms fly out and then they come forward to grasp around something. So very primitive reflex. This is the Babinski reflex. If you stroke up, the baby's toes fan out. Obviously, by 1 year, this will be gone. And if somebody has a positive Babinski reflex and they're older than a year, they have some neurological issues, right? So, but it's normal in babies to have a positive reflex. This is half of the fencing reflex. And then these are bonding behaviors. You can see mom is skin to skin with the baby. The significant other is close by. And then mom and the baby are gazing at each other. So that is definitely a behavior. These are going to be behaviors that you're going to be watching for when you are working with these families. This is bonding after a C-section. Usually with those section babies, we have to suction them really well. We dry them off, get them really warm because the section room is usually pretty cold. And then we let significant other hold that baby. Some places are actually letting baby be skin to skin with mom over mom's chest during the section. Usually mom's arms are pinned down, so it just kind of depends what the policy of the place is. And then these are these are signs of a sick baby. We need to be sure that we tell parents. We got to be sure we teach parents about these. Oh, yeah, now you can't see my thing. And this guy is saying, are we almost done? And look at this. This baby has massive cone head. So I feel like it probably is saying, I have a headache also. The end. Okay, so that was points on the newborn assessment. Thank you.